Good afternoon. Thank you for participating in our monthly virtual Lunch and Learn lecture series. Today, we will be discussing empiric antibiotic selection for diabetic foot infections. After this lecture, you should understand optimizing initial antibiotic coverage in primary care, when to suspect MRSA or pseudomonas pathogens, and when podiatry can offer in what podiatry can offer in collaboration with the primary care provider. Joining us for today's lecture, we have Dr. Kara Brock. Dr. Brock is a clinical assistant professor with the Department of Surgery at the University of Arizona College of Medicine, Tucson, and a podiatrist at Banner University Medical Center, Tucson. Welcome, Dr. Brock, and thank you for being with us today. Please go ahead and take it away.
Hello, so I've been with Banner since May 1st. So while I'm new to Banner, I'm not new to podiatry. I graduated in 2017 from my residency at the Veterans Hospital here in Tucson. I'll be discussing something today that is probably the most common question that I get between both primary care doctors and emergency care, urgent care doctors. When a diabetic patient presents initially with signs of infection and either a new or a chronic ulceration, a lot of times the question I get is, what antibiotic should I put them on? Perhaps they'll be sent urgently for a referral for me, but in the meantime, while we're waiting for the culture results, what do we suspect are the bacteria that we want to cover for? And that's what I wanted to go over today. So we'll go over just some introduction on diabetic foot ulcerations and infections. And then one of the important parts are the most commonly conditions that are misdiagnosed as infection, especially in the primary care setting. We'll go over some of the resistant organisms, especially in the case of the diabetic foot, and then some treatment recommendations that are provided from up to date. So on the picture on the right is a chronic diabetic foot ulcer. You can see the biofilm that is presenting over the granular base. 78% of chronic wounds will have this biofilm, and that promotes antimicrobial resistance. With patients that have infected ulcerations, after a 1-year period, 46% have healed, but the other half, 15% have died, 17% have an amputation, and then the remaining still have the wound. So these are some of the risk factors that are associated. I know everyone knows this for diabetic foot ulcerations, but I'll kind of go over them in a little more detail. Sensory neuropathy. So that's when you have diminished perception of pain and temperature. It's something that's monitored at least yearly, either in the primary care setting or in the podiatry setting with the monofilament test. A lot of these patients will have loss of sensation and not necessarily realize it. So that's why education is so important, as well as providing them with appropriate diabetic shoe gear. We do share a lot of patients with the burn service, and the reason for that is a lot of patients will go home and try to soak their feet in water that is boiling or far too hot and will end up burning off most of the skin of their foot. Unfortunately, it's a very common occurrence, and especially in the hot summer in Tucson, people will walk barefoot across the concrete and develop these burns and not even realize it. As far as autonomic neuropathy, that will lead to dry and cracked skin, especially around the heels. And these cracks lead for an entryway for microorganisms. Motor neuropathy, we really are concerned about foot deformities. We'll especially discuss later about Charcot deformity. And these deformities, especially paired with the sensory neuropathy, will lead to more and more ulcerations, infections, and when you see patients that have these deformities, either their hammer toes or collapse of the midfoot, we really want to consider getting them into a prescription pair of diabetic shoe gear and educating them that there should be no barefoot walking both in or out of the house. The next piece is peripheral vascular disease. So patients, it's important to palpate the dorsalis pedis and the posterior tib pulses. If you're unable to palpate the pulses, I would recommend getting non-invasive vascular studies, including ABIs, and if those are abnormal, arterial duplex. And I know that they went over some of the ways to consult with vascular surgery, and that was last week. So how to diagnose infection? We all know the cardinal signs of infection: erythema, warmth, tenderness, swelling, induration, and purulent drainage. Usually for clinical diagnosis, you want to see 2 or more of these conditions. And sometimes patients can have all of these conditions and they are actually not an infectious process. So we'll kind of go over some of these most commonly misdiagnosed conditions. So the 3 conditions that are often misdiagnosed as infection are acute Charcot arthropathy, venous stasis, and gout. Charcot is probably the most commonly misdiagnosed one, both in emergency care, urgent care, primary care, and even in podiatry itself. It's very difficult to learn to evaluate between Charcot and infection because they do present with a lot of the cardinal signs of infection, including warmth, redness, swelling. There's pain associated, and then these are patients that are neuropathic, so they typically don't have pain in their feet, and so they'll come in saying that they suddenly have this red hot swollen foot. And it's very common with an acute Charcot flare that when they go to the emergency department, they'll be prescribed oral antibiotics, and then they'll come back and say, there wasn't any improvement in the symptoms. Things that you can help to differentiate between infection and Charcot. Charcot is usually localized to the midfoot, and you can see in the pictures on the right that these conditions do present very similar to infection. So you can see the erythema, especially on the right, that looks concerning for cellulitis. The left picture here, you can see a deformity up along the medial aspect of that foot. And that had been previously misdiagnosed as like an abscess, but actually if you palpate it, it's bone. And so Charcot is a condition where the bones of the foot have these microfractures, and every time the patient bears weight on that foot while they're in this acute Charcot flare where the bones are inflamed, then they can continually fracture these midfoot bones and dislocate them to the point that they will have a severe deformity that would need a large reconstruction. So what that means is if you suspect that it is a patient that is diabetic and has loss of sensation, they've developed this redness and pain of their midfoot, it's important to get x-rays because that's really how you diagnose Charcot, is that the x-rays will show these microfractures usually pretty early as well. The periosteum will have these small kind of fuzzy lucencies, and they'll often be this subtle dislocation, or in some cases not subtle dislocation of the midfoot joints. And especially if they're starting to experience some kind of deformity, that patient needs to be non-weight bearing and have an urgent referral to podiatry, where we'll probably cast them, immobilize them, and work them up for Charcot. If you do catch Charcot in the acute phase, there is a very good prognosis, meaning that once that acute flare does resolve, the deformity can be prevented. Now, some patients can be left immobilized for 6 to 9 months with Charcot. It really depends on their disease process. And some patients can be bilateral as well, which is especially hard to treat. So if you do see changes in the midfoot and it's sudden in a diabetic patient, please get an x-ray. Venous stasis is another condition where you have this hyperpigmentation, this wounds that are weeping, sometimes with very heavy drainage. There can be swelling, there can be pain. The Often the skin will be either dry and thickened of the anterior tibial area. And the best treatment for venous stasis is compression. Now, in order to initiate like a medical grade 20 to 30 millimeter of compression, you do want the ABI to be above 0.7. So if you're not able to palpate a pulse, which it's very difficult in some of these cases because of the edema to palpate their pulse, you may want to get a like bedside Doppler ultrasound or get ABIs. And if the ABI is above 0.7, you can usually start an Uniboot if there is an open wound, which will help. That's an even higher level of compression. Usually it's a 30 to 40 millimeter of mercury compression. And that has a pretty good outcome on treating both their pain and their wound. And they'll eventually need worked up to see if they need long-term compression stockings. The next one, and I would probably call this the second most misdiagnosed condition that is confused with infection, is gout. And that's because they also show signs of erythema, edema, and heat to the area. It's usually sudden onset. Pain is usually with very light palpation. Many patients say that they can't even go to bed and put a sheet on their foot just because the pain is so severe. And it's usually localized to the first metatarsal phalangeal joint, although not always. The ankle can also be commonly affected, and I've also seen it in the smaller digits as well as the midfoot joints, although definitely less common. So I would have a high suspicion of gout if there's no wound and if the patient does have pain that's out of proportion. You can order a uric acid, though likely in an acute flare-up that will be falsely negative. Colchicine is something that can be treated for an acute flare. However, it does have some significant GI side effects. A lot of patients will experience nausea and vomiting with that medication, so I do like to warn them about that. The gold standard for an acute gout flare would be aspiration and injection of the joint, but I know personally from experience, patients are usually in so much pain, they will not allow me to touch the joint even after I inject them with lidocaine. So a lot of times it's waiting for the flare to reduce, NSAIDs, Medrol dose pack in the right patient, and then after the flare resolves, then considering them if they're a candidate for allopurinol. So diabetes leads to hyperglycemia, which impairs neutrophil function. And as a result, a lot of diabetic foot ulcerations are polymicrobial, on average about 5 to 7 different types of organisms. So wounds like the one that we see here that are superficial, have some local erythema, usually are an aerobic gram-positive bacteria. Staph aureus is the most common, although group A and group B strep are also common in the diabetic foot. As far as treatment, Keflex or Augmentin usually provide significant coverage unless you have a suspicion that the patient has a history such as MRSA. Personally, I prefer Augmentin. It's BID. It's well tolerated, although some patients do have GI side effects, and you can prescribe probiotic with that. And then the Augmentin will also provide gram-negative coverage, such as E. coli and Klebsiella. So I know that we're able to have some question and answer here. I'm curious if there's anyone that would like to volunteer a response. These wounds are not acutely infected, but they're good examples of chronic wounds. If you were to see, signs of infection with a wound like this, what type of oral antibiotic would you empirically place them on? I don't have any volunteers, so I'll just go over what up to date.
Someone said
Oh,
Levaquin.
someone did say, oh,
Mm-hmm.
okay.
Let me see here.
Levaquin, yeah.
Stuart said Levaquin.
Anybody else? And Levaquin's a good response because you're concerned about pseudomonas. But the bacteria that we're really targeting, because this is a chronic wound, their flora is much different than these superficial wounds. They tend to also be colonized with enterococci and pseudomonas, as well as anaerobic bacteria. Some of the treatment regimens that UpToDate recommended when you want to have coverage for both gram-positive, gram-negative, as well as anaerobic bacteria, you can consider Augmentin and Bactrim, or if you're concerned about Pseudomonas, clindamycin, and Cipro. So I kind of like to think of it as ABC. So Augmentin and Bactrim together, or the C and the C, the clindamycin and the ciprofloxacin. And one of the reasons for Cipro over Levaquin is certain geographic susceptibilities for Pseudomonas, and including Banner. I'll have the diagram later. Ciprofloxacin tends to be more effective at Pseudomonas treatment than Levaquin, just for this geographic location. Necrotic wounds. You want to include coverage for Bacteroides and Clostridium. You're concerned about an anaerobic infection. If you see one of these infections in the primary care setting, this patient needs to go to the emergency department right away, and that patient needs to have an emergent incision and drainage. The picture on the right, although it looks subtle, you can see this necrotic wound developing over the dorsal aspect of the fifth metatarsal phalangeal joint. That patient actually lost both their fourth and their fifth ray due to a gas-forming organism. They had a necrotizing soft tissue infection, and then as well as this patient on the lower aspect here had a very large debridement of this heel wound that required serial debridements. And those patients will need very urgent follow-up if you see any soft tissue gas in an x-ray. That needs to go to the emergency department. So the working group for, let's see here. The guidelines for diabetic foot ulcers, they report for empiric therapy must be based on clinician's best guess at the likely causative pathogen and the local antibiotic susceptibilities. So, well, that sounds very nice. That leads to the question of what can we suspect is the causative pathogen, because we just learned that diabetic foot ulcerations tend to have polymicrobial infection. And so we need to really think about what we want to cover and while we're waiting for these culture results, because some of these infections can spread very quickly if the inappropriate antibiotics are not selected. So this is from an article that was published in 2022. It reviewed 10 years of data at a single center and included 3,733 specimen that was taken at the Baylor College of Medicine in Houston, Texas. While it was limited because it was a single center, it is a very large study, and so it gives us a little of insight to what the common microbial isolates are in the diabetic foot. And this has been a consensus over multiple papers that Staph aureus is the most prevalent bacteria. The runners-up have been somewhat debated. Corneobacterium is listed here. E. faecalis, group B strep is something that we see pretty commonly here, as well as E. coli, Pseudomonas, Klebsiella. And so this is the antibiogram that I was discussing earlier. And if you are going to be routinely prescribing antibiotics at a facility, it's great if you can review the antibiogram. It can be found on Banner Connect. If you go to the search page and just type antibiogram, it actually is very easy to find. And that goes over the site-specific bacteria and susceptibility data. They have it for main campus as well as South Campus. They're pretty similar, but it does show some differences. So some things that you can note when you review the banner antibiogram is that for MRSA, clindamycin is only 61% susceptible. So if you are concerned, it's better to use Bactrim or doxycycline or linezolid if you can achieve getting it. It's worth noting here because it is on the antibiogram is that rifampin is good against MRSA, but it is not a appropriate monotherapy. It always has to be a dual therapy. And there are very significant drug interactions with multiple medications, including anticoagulants, methadone, hypoglycemic agents, contraceptives, barbiturates. Very high rate of interaction with other drugs. I know I've had friends in pharmacy and they consider rifampin a nightmare drug to try to prescribe with anything else. And it's a cytochrome P450 inducer. And so while it can be great against a variety of bacteria, it's not commonly used. It also causes your tears and secretions to be red. So not one that's commonly used. This is just the second page of the antibiography, and this is the one that shows that ciprofloxacin, if you look here, is here. Hold on. I'm trying to find the. Sorry, it's very small. So I'm not able to find it in this page. Oh, here it is. Pseudomonas. Ciprofloxacin is 89% susceptible, while levofloxacin is 82. So now I'll review just some of the resistance organisms. MRSA is the one that everybody knows and loves. The risk factors are prior antibiotic use, a history of known colonization. So all of my patients that have diabetic foot ulcerations that develop an infection, I like to ask them, do you have a history of MRSA? Oftentimes, if they're not familiar, they'll say, yeah, everybody came in with yellow gowns when I was in the hospital last time, and that should indicate that it may want to include additional coverage. Previous hospitalization, patients that are in SNFs or patients that have IV drug use are at higher risk for MRSA infection. MRSA infections tend to be more invasive infections. Oral treatments, clindamycin, although we saw that in this geographic location, may not be ideal. Linezolid can be a great oral therapy, but can be difficult to get improved by insurance. Bactrim and doxycycline are both excellent. I know Bactrim has interactions with warfarin, which does limit its use in some of our patients. So this patient on the right is a recent inpatient that had a MRSA infection and developed MRSA bacteremia. He subsequently went through 5 different debridements before his white count stabilized. MRSA infections tend to be quite aggressive and have frequent reoccurrence, increased hospitalization, and an increased mortality. So that's why it's important whenever there's a clinical suspicion to cover for them. So the next case, and I feel like this is one that is overlooked more because MRSA gets so much attention, but Pseudomonas is actually a bacteria that can be very aggressive and is undertreated, undercovered in empiric therapy. Risk factors are tropical climates, patients that soak their feet in warm water, and burns as well can develop Pseudomonas infections at a higher rate. Symptoms of a Pseudomonas infection include green drainage and macerated wounds, especially if you look on the right. That was a recent patient of mine that I had. He was actually being treated for a MRSA infection with infectious disease, and he was on long-term IV antibiotics for MRSA when he suddenly developed this new redness. And I took a culture and it did come back as pseudomonas. And so he had developed a subsequent new infection. And the reason why it was not improving on his current regimen was that it was a pseudomonas infection that was resistant to the antibiotics he was on. So oral treatments include ciprofloxacin and levofloxacin. And so back to the anaerobic organisms, risk factors, necrotic wounds, deep wounds, and ischemia. These wounds tend to be malodorous and can develop soft tissue gas, which will feel like crepitus on exam. A lot of times when patients develop these types of infections, they appear acutely ill. They're nauseous, possibly feverish, vomiting. These patients need to be emergently admitted to the hospital, and they need IV antibiotics. One thing commonly missed in the emergency department is that these patients should have clindamycin as part of their IV regimen. So if you're admitting a patient, it's starting them on clindamycin as soon as possible will be beneficial, and then urgent surgical debridement. And as far as anaerobic organisms themselves, it's not clear in the literature if anaerobic organisms manifest as more severe infections or if they're really more opportunistic colonizers on necrotic infections. So it's kind of a chicken and the egg. So on obtaining cultures, you should really only obtain a culture on a wound when there's a clinical sign of infection. If there's a mild infection and you don't have a suspicion of a resistant organism, usually treating them with empiric therapy is all that you would need. If you do feel that the patient has a history of resistant organisms, or if they're a high-risk patient, you usually want to take the culture before you start the empiric antibiotics to get the most accurate results. As far as taking the culture itself, the recommendation is to do this after you do a superficial debridement of the wound. Now, I know not all clinics have the capability to do wound debridements or tissue cultures, but tissue cultures would be the most effective and more accurate than a swab culture. And whenever the patient does have surgery, we do send the tissue specimens that will be deeper tissue and more accurate than the superficial swab. And this is from UpToDate. What constitutes a mild, moderate, or severe infection? Because remember, the mild infections usually don't require a culture swab. The rule of thumb that is in UpToDate is about 2 centimeters of erythema around the wound. Now, you do have to consider other things like lymphatic streaking. If there's gangrene or involvement of the muscle, then that would be considered a more moderate severe infection. But if the erythema is less than 2 centimeters, the patient is low risk. Usually empiric antibiotics are appropriate without culture. So these are guidelines from the International Working Group on the Diabetic Foot. They go over mild or moderate, as well as what type of pathogens to cover. So for example, a mild infection, you're really just covering group positive or gram-positive cocci, and a Keflex or an augmentin should cover that. If you've had recent antibiotic exposure, those are the ones you're concerned about. MRSA, you want to maybe consider linezolid, doxycycline, or Bactrim. And then here discussing for gram-positive and gram-negative pathogens when you're concerned on that. Some of the antibiotics they're recommending are IV, and certainly if the patient warrants admission for IV antibiotics at that point, then that would be more appropriate. And these are similar guidelines from UpToDate, and those were previously in my slides, that if there's a superficial infection, usually targeting gram-positives again. If you're suspecting MRSA, clindamycin, or more appropriate in this facility, Bactrim or doxycycline. I feel like a discussion on diabetic foot infections would not be complete without some mention of osteomyelitis. Now, there's always the question of should the primary care doctor order an MRI prior to referral to podiatry? And the answer is usually no. If there's an X-ray sign of osteomyelitis, then an MRI is not usually necessary. A couple of reasons for that is that Charcot arthropathy, which we discussed previously, that's frequently misdiagnosed as osteomyelitis on an MRI and can lead to increased interventions, bone biopsies on patients that may not necessarily need them. Bone biopsy is the standard for diagnosis of osteomyelitis. So if a patient already has a wound that needs to go to the operating room for a debridement, usually we'll obtain a bone biopsy at that time. And if we know that we're going to the operating room, an MRI might not be needed because the bone biopsy will be more accurate and the MRI will not change our plan. Now, when there are times that the patient has symptoms of like a chronic wound that has signs of infection or it's worsening and not healing, the X-ray does not show signs of osteomyelitis, then it may be appropriate to order an MRI. Or if you refer them to podiatry, we will be happy to order it as well. And MRIs, they're very sensitive at detecting osteomyelitis at 97%, but the specificity is only 77%. So that means, 23% of patients that have these MRIs, they may be misdiagnosed. And this is one of the studies that is pretty recent from the New England Journal of Medical Medicine in 2019. And I feel that the standard of care with treating osteomyelitis in the diabetic foot really has not caught up to some of the literature. I know the standard has been for decades to be IV antibiotics for 6 to 8 weeks. However, these newer journal articles that are very high evidence have indicated that oral antibiotics are actually not inferior to IV antibiotics when treating osteomyelitis. So this was 26 different centers in the UK. They had over 1,000 participants, and the treatment failure at 1 year in the IV group was 14.6%, but then 13.2% in the oral antibiotic group. And oral antibiotics, as we all know, are much more tolerated. There's a much less cost involved, especially with getting patients into either home care, or many patients have to go to SNFs for months for this care, and treating them with oral antibiotics could be much more an improvement in their quality of life while they're undergoing treatment. Now, we still work with infectious disease to discuss which patients are appropriate candidates for oral versus IV antibiotics. I will say I still see a majority of our patients getting a PICC line and going to SNFs for IV antibiotics, but I have been very successful in treating dozens of patients with osteomyelitis using oral therapy alone. So in summary, empiric therapy should be based on history and clinical findings. If a patient's been recently hospitalized or has recurrent infections, include coverage for MRSA. And if the patient has any macerating wounds, you do want to include coverage for pseudomonas, as I feel like this is something that's overlooked quite a bit. And just a little bit about our team. So we are now a team of 5, which has really expanded in the last year and a half, because originally it was just 2, just a short 2 years ago with Dr. Poplardo and Dr. Rotman. And then over the last year and a half, we've added Dr. Cole, myself, and then our new chief is Dr. Hall, who just started last month. So we really have the capability now to finally get patients in quicker, see more patients. We are a very heavy operating team, so we all do dozens of surgeries on a weekly basis. And so we each are taking call both at main campus and the South Campus. And we are all very approachable. If you have any questions, we're happy to answer them. I did leave my contact information. If anyone has any questions or about a patient and you want to call me, you are more than welcome to do so. But I did want to open it up for questions if anyone had any questions regarding diabetic foot ulcerations, infections, or anything podiatry related.
Any questions, concerns, or comments for Dr. Brock? Great information. Thank you. Well, if there's no questions, no comments, then thank you very much for your time, and we will see you again. Oh, sorry, I see one's come through. Well done. I had a patient today that I never considered acute Charcot. We'll follow up on him. Perfect. So then maybe you got some information from our lecture today. That's excellent. If there's any questions, feel free to reach out to Dr. Brock directly. Otherwise, she said so timely. Otherwise, we'll see you next month for another Lunch and Learn lecture. Thank you, everybody. Have a great day.
I'd rather hear footpaths. That might help me.